So in our next session here, we're going to move into talking more about some of the actual issues with some of the new products that are out there for patients, including drugs. And in this session, entitled Unbundling with Purpose, Designing a More Patient-Centered Payment System That Reflects Patient Priorities, we're going to be joined by Dr. Ankur Shah, who's the Assistant Professor of Medicine, an Associate Program Director for Research, and the Medical Director for Peritoneal Dialysis at the Division of Kidney Disease and Hypertension at the Warren Alpert Medical School of Brown University. So, Dr. Shah, why don't we go ahead and get going on this because I think your insights are rather telling about the bundled payment system.
Absolutely. So first of all, thank you for having me here. It's really exciting to be able to share my insights to this group, and I feel like I've already learned a lot from the prior speakers and looking forward to the next speakers as well. And I want to start by talking about a problem. So I wear a lot of hats. I am a clinician, I'm an educator, I'm a researcher, and through all of those hats, I think what I've found is that there's one kind of common thread of issues going through kidney failure treatment. And I'll start with myself as an educator. I started practicing in 2018, and I did a lecture for our new fellows on fundamentals of dialysis. I've done that lecture every year. I'm doing it again next week. And for the first 6 years, I didn't have to update my slides. Where is our innovation? Where is our progress? But excitingly, I actually get to update my slides next week because I get to talk about hemodiafiltration. And so one of the things that I recognized was that I'm not seeing progress in my field, but I am seeing progress in other areas of kidney disease. Dr. Watnick talked a little bit about progress in chronic kidney disease treatments. We've seen a lot of new therapeutics for things like IgA nephropathy, for people with diabetic kidney disease. And while I would love to be made irrelevant as a dialysis researcher, there is a bit of an irony of going into a field that you hope is made to disappear one day. And I would love to one day have to recreate myself. We're not there yet. And I have patients right now who need help right now. I personally care for about 50 people on dialysis right now, and I would love to not have anybody on dialysis, but those 50 people need help. They need things to change. They need things to change now. And as a clinician, I do note that we do have new medications that hit the market, but I don't have access to getting them into my patients. I look at new medications for itch. I look at new medications for phosphorus. I look at new medications to help prevent infections. And then I look as a researcher and I look at the United States renal data system. And what I see is they're on the market, but they're not in patients. They're not getting there. And so that goes back to myself as an educator. I can tell people that there is innovation, but I can't tell them that you're actually getting this into your patient. So we have an innovation to execution gap. And then also as a researcher, I look back to that United States renal data system. I look at the dialysis outcomes practice pattern studies, and I notice something. If you look at patterns in mortality in people with kidney failure, particularly those on dialysis, around 2011 to 2013, you start to see a change. This was chronically getting better for years and years and years, and since 2013, it really started to plateau. And so that had me wonder, well, what happened around that time period? And I discovered it all comes together. Unsurprisingly, one of the nice things about wearing a lot of hats is when they all come together, but it comes together to the bundle. And I think that the bundle has really stifled both innovation and implementation. And so as I look to the bundle, I do want to highlight, though, there were good things about the bundle. So the bundle, in my mind, is allowing me to practice 2011 medicine at the best way possible. And the bundle was implemented in 2008. It was proposed in 2008, I think it was passed in 2008, sorry, implemented in 2011. And if you look at what happened with the bundle the first couple of years, you do see things like an increase in home dialysis. You see reductions in erythropoietin stimulating agent use in patients who maybe would not benefit from them without reductions in patients who would benefit from them. You see costs go down, and you do see that mortality curve continue to improve for the first couple of years of the bundle. So I think the bundle really helps us practice the best of 2011 medicine. But I was not even in medical school in 2011. So I don't know that I want to be practicing the best of 2011 medicine. I want to be practicing the best of 2025 medicine. And I think that the bundle it's given and it's taken away. And so the reason that I'm here is I think that we need change because my 50 people on dialysis who I take care of every week and the hundreds of thousands who I see in data sets all need change. They need it now. That's my perspective.
Thank you very much. And let me follow up with 1 second, Doc, and ask you this. So on Capitol Hill right now, we have nearly an entire generation of congressional staffers who are working very diligently to represent the concerns of kidney patients in their districts for their elected members. And the bundled payment system, as you indicated, dates back prior to their time on Capitol Hill and prior to their time in school in many cases. And so, in the simplest way possible, can you talk about an analogy that people would understand? For example, if you had a $100 bill and you had to pay for everything with it, what does it look like in practical terms to have a bundled payment system for all kidney care? What happens if an innovation comes along? What is the dynamic that is created if a provider is only getting the $100 bill for everything? What is the dynamic that happens on that payment?
That's a great question. And I think the way that I would describe that is if you have a $100 bill to pay for dialysis, and then next year somebody says, we have a $10 therapy that is going to make your life better, if you still only have that $100 bill, paying for dialysis is kind of like being on a fixed income. It's the same thing of when I tell my patients who are elderly on a fixed income, I have novel therapeutics to offer you. They have to figure out what subtracts to add that novel therapeutic. And dialysis is the same way. Either we have to find something to subtract to add something new in, or we have to say, I don't have anything to subtract. I have patients who say, I have things I can subtract to add something new in. I also have patients who tell me, I can't trade food for this. And so it's being on dialysis and paying for dialysis is like being on a fixed income, would be the analogy that I would share.
Okay, thank you
And it's
very
a rough way to live.
No, I think it's an illustrative example for people to understand what's happening in the kidney space and has been happening for a long time. Thank you very much.